Welcome everyone to the June 9th COVID-19 clinical care rounds. Critical care, the ugly tale of ARDS. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 critical care challenges and successes in patient care and operations. Today, our focus is on ARDS, frequently discussed in prior rounds. If I'm an intensivist preparing to care for many COVID-19 patients, especially with ARDS, the clinicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated on these rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care with other clinicians. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. And thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, June 11th, will be emergency department rounds focused on ED, nursing, recovery, and preparing for a second wave. Look for announcements for next week's rounds. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO rounds we've had to date, we continue to have participants from all states and other countries, predominantly physicians, nurses, and EMS clinicians. We apologize in advance. We're not going to answer all the questions we receive, but pick out major themes from questions and hope to cover some of those. Dr. Bruce Struminger will now go over some logistics.
Thank you, Rick, and welcome to all our participants from across the US and around the world. And thanks to our two presenters today and to our expert panel. Just gonna share a few logistic items. Hopefully everyone can see at the bottom of their Zoom screen a Q&A function. Please put your questions and comments regarding today's presentations and the discussion in that Q&A space. We'll be looking at that and keeping up with those questions and comments. In the chat function, also along the bottom of the Zoom toolbar, if you've got technical or logistic questions, put those there. Also, in a few minutes, Rick will ask a crowdsourcing question for your feedback, and please put that feedback in the chat section. We are recording this session, and your attendance is consent to be recorded, so thank you for that. The presentations are linked to the most recent email announcement that you should have received this morning from Project ECHO. They will also be on our website, and we'll share a link to that website and at the bottom of the future announcements, as well as a link to the recording of the session. We're offering CME and continuing professional development credits about 15 minutes before the end of the session. We'll put a link to the CME questionnaire. It's an anonymous questionnaire. You will then get instant CME and be able to print out your certificate. We really value your feedback, so we really encourage everyone to take advantage of the CPD offering and give us your feedback so we can continue to improve these clinical rounds. That link should also be in today's email announcement from Project ECHO. Normally, our colleague Sharon Van Arsdale from NETEC is on with us, but I don't see her here today. So I just want to remind everyone that NETEC offers a series of webinars, and they have a webinar coming up this Friday. The focus is on workforce innovation, how to reassign, redeploy, and leverage advanced practice providers and staff during the COVID-19 pandemic. So please go to their website and register for that. They have also access to the recordings and PowerPoint presentations from previous sessions. Also, one of our collaborating professional societies is the AAMC. They have put together a wonderful clinical guidance repository, and the URL for that is here. We'll put that in the chat. They keep this updated regularly, so please visit that repository to take advantage of the wonderful resources they've put together there. With that, I'm going to hand the microphone back to Rick. Rick, you're muted. Great.
Thanks for the reminder, Bruce. And also, I do appreciate, Bruce, a reminder about the CME piece. I hear it every rounds, just like I hear myself do the introduction, and yet I like don't take advantage of the CME piece. So I need to jump on that and hope participants will as well. So for crowdsourcing Clinical Pearl today, the topic for today is ARDS. And so probably worth your sharing your experience. What approach to ARDS and your COVID-19 patients has worked the best. Please share that with your colleagues who are participating. I'd like to now introduce our panelists. Let's see, Dr. Bittinger, and I see Nancy and Sarah, so if you wouldn't mind going off mute and see if we can get you to introduce yourselves with title, name, title, and affiliation. Paul.
Paul Bittinger. I am an emergency physician at Mass General Hospital in Boston, and I'm the director of the Center for Disaster Medicine here.
Thanks. Nancy, if you could. All right. Well, we'll go to our first presenter then. Let's see. Our first presenter, Vikram Mukherjee. Dr. Mukherjee is assistant professor of the NYU School of Medicine and director for the Bellevue Medical ICU. Vikram, welcome back.
Thank you for having me, Rick. Let me just share my screen. Okay, can you hear me? Slides look okay. Okay. Thank you for having me back again. For the next 5 or 10 minutes, I'd just like to describe what we're seeing after the acute phase of respiratory distress has passed, and how the survivors of this critical illness are often left with a significant disability. So I'll start with the case. Our gentleman here is a 40-year-old male with no known past medical history, admitted to our ICU with COVID pneumonia manifesting as severe acute respiratory distress syndrome, and more importantly, just had single organ dysfunction at the time of presentation. This is an X-ray from a month or so prior to admission, and as you can see, it's a fairly normal X-ray with no obvious lung disease on it. The ICU course of our patient was quite common to many patients that were here in the ICU, and it essentially started with an ICU admission requiring intubation. To keep them synchronous with the ventilator, we had to use deep levels of sedation with fentanyl, propofol, often midazolam, and off and on used to need cis-atracurium and neuromuscular blockade to keep patients compatible with the vent. Off and on, we were using steroids, sometimes to suppress the cytokine storm that often accumulated in these patients. Given the steroids and the off and on the long duration of ventilation, we saw a vent-associated pneumonia in a few patients and also in this patient. Unfortunately, after around 14 days of trying, our patient was not able to come off the ventilator, needed a tracheostomy, and is now on a long-term wean. Now, a lot of the things that happened between ICU admission and long-term wean were necessary to provide safe care to the patient, but has significant consequences to the overall outcome. For example, we know that a benzodiazepine drip has issues with sedation, a longer ICU length of stay, longer ventilator days, and post-ICU PTSD. We know that Nimbex and steroids, cis-atracurate and steroids, are a horrible combination with a significant incidence of neuromuscular weakness. As you know, vent-associated pneumonia makes your lungs even more prone to weakness. I want to run this slide, and then we'll come to specifics slides on this, but this is a CT with an overall glimpse on how this patient's lungs looked. Now, this is a month after the patient's initial presentation with ARDS, and this is how the CT looked a month out. We'll come to some more specifics to the CT, but I just want you to have a global overview on how diseased the lungs are after the acute inflammation has subsided. Going through some specific cuts of the CT, up in the apices, we still see some areas of active inflammation in the form of ground glass opacities up here. But as we go through the bases, we see what essentially is fibrotic lung disease as a consequence of the ARDS. The ARDS now, a month out, has progressed to fibroproliferative or fibrotic ARDS. And here you can see signs of fibrosis here, some bronchiectasis here with dilatation of the airways, further disease, and quite subpleural in distribution here. But as you can see here, these dilated airways are a consequence of fibrosis in the lungs shrinking over time because of the ARDS and the disease. Again, here you see more fibrosis here, some areas of consolidation, but significant amount of bronchiectasis. And at the bases, these are more pronounced, where you see the airways being very abnormal, the lungs being extremely fibrotic. And the point I bring out of this is because these are terminal changes. These no medication, time, none of these are going to heal these very diseased lungs. These are scarred lungs with horrible disease which have no recovery in the foreseeable future. So what I want to convey over the slides is that a significant majority of our patients who presented with ARDS to the ICU passed away, close to 50% mortality. The survivors are by no means healthy going home. They have, what we are seeing now, are long-term consequences of COVID ARDS in the form of fibrotic disease, in the form of neuromuscular weakness from the disease, from the medications we sometimes have to use. So some of them are consequences of medical care, but a lot of these are evolution of disease, and that's a one-way street. The fibrosis is not going to get better. What this also implies is that there is an evolving need for long-term critical care. Here in New York City, we have hundreds and thousands of patients behaving and left with stigma of chronic critical care, which gives the city a need for long-term acute care capacity building, ventilator weaning, and for any substantial improvement in quality of life, physical therapy, nutrition, and nursing care are imperative to provide for the chronic critically ill. Lastly, because our patients now are so frail from the horrendous critical disease they've gone through, the chances that they come back to the ICU with a blood clot, with a pneumonia, with a pressure sore is extremely high. And we anticipate seeing a fair back and forth for a patient between a long-term acute care to a nursing home to the ICUs and back and forth. So I don't mean to paint an extremely sobering picture, but just because a patient has survived a rough ICU stay doesn't necessarily mean that his or her troubles are over. The long phase of critical illness is fraught with a lot of disease and debility. Thank you.
Thanks, Vikram. I've got a couple questions. So all the patients that you've discharged, how many or what percent have been readmitted to the unit because of basically what you've described?
So we have the data to show how many patients from the ICU to the floor have come back, and that's around 10 to 15%. The ones that we have discharged to a LTAC haven't started coming back yet, but we do anticipate them coming back with one of the things we spoke about.
Yeah, and Vikram, I'm trying to think back to, back to March. And you were seeing patients in March. I know you were seeing a lot of patients in March. What, as you have started to learn about the long-term sequelae, what do you think the approach in terms of their follow-up, your ideal approach to follow-up, is that involvement of the intensivist? Is that a special COVID clinic? Is that back to their, right? I mean, what, in the ideal world, which this certainly we got a lot of ways to go, but what do you think the approach may need to be in the future with this?
Oh, that's a great question, Rick. And some of those answers are still evolving. My best guess would be a two-pronged approach. One is to make sure the patient and the patient's family are prepared for this long phase. As we take care of the patient, especially peri-intubation and through their ICU illness, I think it's our due diligence to make sure that the family members are aware that this is going to be a long haul and they shouldn't expect any miracles in the short term. The second thing is, yes, there is a case to make for an ICU clinic. It's been well described in the non-COVID literature for ICU survivors. But here, as we see more ICU survivors with more, pulmonary issues and sometimes renal issues as well, I think there's a case to make for a COVID clinic or a post-ICU clinic with some support, if not run by an intensivist, because the pulmonary part, the chronic critical care part is extremely relevant to this.
Yeah, thank you. Any questions from our panelists before I move on? All right, well, thank you. Thanks very much, Vikram. A lot to think about for sure. Our next speaker is Dr. Will Bender, Assistant Professor of the Division of Pulmonary Allergy, Critical Care, and Sleep Medicine at Emory University School of Medicine, and the Site Director for Critical Care at Emory Emory Critical Care Center. Will, please.
Thank you very much. Let me see if I can get my screen shared here. And you guys can hear me okay? All right. So I'm going to kind of take this in a similar format as Vikram and just kind of walk through a case that I actually just recently had coming off service and kind of highlight some of the issues we're seeing as we, I think, globally get a little bit better idea of how to take care of these patients and potentially get more and more of them through their ICU stay. I have no financial disclosures, but the case I'm presenting here is a 76-year-old female with a reported history of diabetes and hyperlipidemia. But it's interesting to note that once she was sick in our ICU, her family noted some previous issues with reported dyspepsia, reflux, and even kind of intermittently reporting shortness of breath to family members. But she came into our one of our emergency rooms with a 2-week history of fatigue and decreased appetite, denied up and down any sick contacts or exposures, but ironically was working as an office manager in a rheumatology clinic that at the moment at least was closed and not actively seeing patients. Skip ahead. On arrival in the emergency room, she was noted to be pretty hypoxemic, 73%, and her COVID nasopharyngeal swab was PCR positive. She progressed from a non-rebreather to a high-flow nasal cannula, and we were able to kind of keep her stable on that for about a day to a little over a day and a half. But due to just worsening work of breathing and due to progressively worsening hypoxemia, she was ultimately intubated on hospital day 2. And what's interesting is her D-dimer on presentation was 56,000. And I know almost all of us throughout the various courses of our training are used to kind of blowing by D-dimers and scoffing at them. But I feel like in this era of COVID, I'm now focusing on them intently when they pop up on their lab results. And interestingly, as part of our protocol at Emory, we get POCUSes on everybody and do them fairly frequently. And her left lower extremity was notable for a fairly sizable DVT and a mildly enlarged right ventricle, although her CT imaging did not reveal any evidence of pulmonary emboli, or I should say overt pulmonary emboli. And this is just her admitting chest x-ray, and we can certainly see some kind of interstitial areas kind of more prominent on the right side. And as we move into her CT scan on arrival, which we got on her transfer up to the ICU, just as we scroll through a couple of cuts here, you definitely see a more apical involvement and some dense consolidative changes. I highlighted this slide, as you can see, what appears to be a patulous esophagus. And as we work our way south, and it doesn't project as well here, but her esophagus definitely appears thickened as well. And as we work our way further south in her chest, I think you can raise the argument, and I've talked with some of our ILD specialists about this as well, if there's definitely some areas of bronchiectasis and even a little bit of traction in here as well, thus raising the question of even some underlying lung disease hiding in here that we've now kind of discovered in the setting of COVID. Either way, it's a pretty horrible CAT scan, and overly not surprising that she ultimately ended up intubated. Her case in the ICU was notable for, we utilized a regimen of fentanyl, ketamine, and dexmedetomidine to kind of keep her sedated, targeting a RAS initially of about -2, and utilized a lung protective strategy. And she actually had fairly robust compliances, which I was a little bit surprised about. And we were able to kind of maintain a low PEEP ladder with her. Given her clot, we obviously used a high standard heparin drip, and as her course stabilized, we switched over to Lovenox. And I actually used a regimen of inhaled heparin with her. I'd love to immediately put up on the screen an RCT that demonstrates my desire to do so, but this was more gestalt than anything else, and based off some of the recent autopsy data. Interestingly, despite the somewhat impaired RV, she had very minimal vasopressor requirements throughout, and we utilized a fairly robust airway clearance regimen at Emory, so we kind of hit her hard with that. We were able to procure use of remdesivir as well. Given her presence of a clot, we were unable to get her enrolled in Act 2, but we were able to get her compassionate use. And ultimately, she was extubated high-flow nasal cannula on hospital day 8. So interestingly, kind of a shorter presentation to her case as compared to Vikram's patient. But as we've moved forward with her care and worked on stepping her down, as an older patient, several long-term care needs have been identified. Obviously, anticoagulation. While we've been able to obviously get her extubated and down from a high-flow nasal cannula, she continues to require about 4 to 6 liters of nasal cannula currently. So and it's very likely you're looking at someone now with chronic oxygen therapy. And then, despite her, I would say, quote unquote, robust recovery, she's still demonstratively weak and has ongoing physical therapy needs and occupational therapy needs. And as we begin to think about discharging her, these are part of her robust plan of care going forward as well. And as we've transitioned her and a few other folks like her out to the floor and out of the hospital, one of the things that we've been struck with is the overall system preparedness for the long-term care needs of these patients. Obviously, they have long-term sequelae from their critical care illness, but also just general sequelae of being in the hospital. And this is a population that, I think the system as a whole may not be necessarily ready to address. And while we talk about needing long-term, ICU type clinic follow-ups, I think just these simple physical therapy needs, these simple chronic oxygen needs for these patients are something that, as we look at the system as a whole outside the hospital, I'm not entirely sure that we're ready to handle this deluge of patients, particularly as we get a little bit better managing these folks in the ICU. So with that, I can kind of stop and take any questions. I'm going to stop sharing my screen.
Yeah, thank you. We got quite a number of questions. One I've got for both of you. Let me start with you, Will. What's the trajectory of these patients on discharge? Okay, so is it to step down unit to then long-term care typically? Is it, okay, discharge and then 4 days later, discharge to the floor, then 4 days later out the door? Is it to like PT? What's the sort of like trajectory of these really complicated patients with chronic needs? Yeah, Will, why don't you start in your system? How going? And it may be, I understand it could be like, so well, it's different for every patient, but do you see some trends with it?
Yeah, no, absolutely different for every patient. But I would say, for the more classic folks that we're seeing in the hospital with COVID, it tends to certainly be from our institution into another institution with a decent cohort requiring LTAC level care, long-term acute level care. So definitely a higher level of care and care needs. But there is a cohort that we've been able to get out to rehab type facilities. So a little bit lower level needs, but certainly a group that, I think the system as a whole is still not fully prepared for that onslaught for. And again, not to kind of harp the point, but I do just wonder, as we get a little bit better at this, that as we kind of talk about this quote unquote second wave, I do worry about some of these downstream manifestations of, we know getting people out of the hospital in general, they tend to do a little bit better. And if you're ready to go, we got to get you out. And so I worry about our system's downstream capabilities, particularly as we also deal with some of the mass media societal thoughts towards, hey, a lot of this was in nursing homes, a lot of this was in those type of facilities. I think those institutions are going to be key. And again, I just worry about our system's ability to kind of handle that as we get a little bit better at this.
Actually, it's a really important point with the focus on long-term care facilities and the challenges with them with those patients getting the virus, and then we're like looking at that as a support system for those being discharged. I actually hadn't thought about that, and it's a really important point that you bring up. The other question, and then I want to turn over to Vikram with actually the same question from your perspective with this. But so, Will, does the discharge trajectory track with the high-risk patients going to the more intense care, or is it a little bit more random and very patient-specific? I'm not sure I'm asking it very well, but it's sort of like, are the high-risk patients, those are the ones that are going to get the long-term real big problems, or is it a little bit more idiosyncratic?
I think it's, to be honest with you, I think it's still a little too early to definitively say as we kind of get all of this figured out. But in general, I think the folks that we're seeing that higher level of acuity to start, or them devolving on their presentation into a higher level of acuity, are requiring that higher level of acuity or a higher level of care on discharge. And obviously that would be the population that you would anticipate potentially either taking some steps back or tipping back over into trouble.
Thanks. And there's a specific question we got about what % of your patients you're discharging are going to LTACs, approximately?
I'd say probably a third or so right now, maybe a little bit harder. It's tough to fully, it's kind of variable as we're kind of, on a daily basis, adding to the numerator and denominator here.
Yeah, and I just see, I saw a comment about chronic disease after 9/11 and those challenges. Also, strikingly, after some of the mass casualty incidents we've had, some of the mass shootings we had, some of those challenges as well in terms of like long-term care. So trying to figure this one out for this population, especially given the numbers, is going to be, it's really, Vikram, I'm glad you brought this to our attention. We need to talk about this. Okay, so Vikram, your thoughts on this?
So agree with what you and Will mentioned. Around a third to 40% of our survivors are also heading to LTACs. And, just in the H&H network, so for the audience, Bellevue is part of the New York City Public Health Network, which has 11 hospitals. And so far, we've seen around 3,000 critically ill patients, 10,000 inpatients. So even suppose we're looking at a 40-50% mortality, 40% of survivors is still 600 odd new LTAC beds that the city needs to cater for these patients. And that's just the public health network, not taking into account the New York City hospitals like Columbia, Cornell, Sinai, what have you. So the need for building up long-term acute care capacity, also knowing that a lot of these patients who go to long-term will come back to the ICU at some point in their trajectory, really means that we have to build capacity now without even considering a second wave. When that hits, it's just going to ramp up the needs even more. Just to put it in context, for example, there's data from around 5 or 6 years ago from Duke, which shows what happens to 100 odd patients that go to a long-term acute care after a trach and a PEG. around 70% of them will die in a year. Around 30%, 20% or so will go from an LTAC to a nursing home to an ICU and back and forth. Only less than 10% will ever go home. So we're looking at a pretty active and expensive and moribund year for the survivors of this horrible illness.
Thanks. There's a comment here, and then there's some questions I want to ask two of you as well. Comment: in these times, do we perhaps need to even consider a disease-specific facility for long-term care, much like TB sanatoriums would reduce exposure in nursing homes, et cetera? Just a thought. Good thought to start thinking about. Let's see, another one. This question, any special guidance for patients discharged from tertiary care at a low elevation? And as soon as I saw low elevation of D-dimers or what, viral load, but it's about like 1,500 feet. Okay, so 1,500 feet. Any special guidance for patients discharged from tertiary care at a low elevation, approximately 1,500 feet, returning home to high elevation, 6,000 feet? How about duration of antiplatelet therapy and/or coagulation? I know there hadn't been a RCT on this one yet, but your thoughts?
So with regards to anticoagulation at Emory, we have kind of a tiered system for anticoagulating these patients based on their clinical appearance and some of their lab characteristics, much like some of the other larger institutions. I know Mass General has something, I believe Duke has something, and all of this information is kind of out there. We, obviously for someone with clot, the kind of the indications are kind of what they previously were. For folks that don't have clot but still have certain elevations in coagulopathy parameters, we do a prolonged course of anticoagulation with them as well. And much like my point about inhaled heparin, it makes sense, but do I have the RCT to kind of throw up here in front of everybody that says it really should be done? I don't. So.
Yeah, thank you. Vikram?
Agree with Will. The high altitude question is an interesting one and not something that I had thought about. And the same question goes for, is it safe to fly after you have one of these because of the
Yeah.
I think a very good question, relevant. I don't think we have really good answers. I would be a bit cautious because if you have such horrible lung disease, gas exchange is going to be impaired. And if you go to a place which puts you at higher risk for hypoxia, be it high altitude, be a low cabin pressure in an airplane, you might become hypoxic to an extent that's dangerous. So I would hedge on this and say, see your pulmonologist before doing that.
Yeah, the studies definitely haven't been done yet, but it's a great question to consider. And the flying piece, yeah. Let's see. There's one more really specific question, then I'm going to do some polling here. It's a very specific one. What are the common causes of fever at the time the patient is recovering from cytokine storm, but still on the vent and renal replacement? Is it usually secondary infections from the treatments or thrombus emboli? Are there other key considerations? Vikram?
That's a great question. As these patients stay in the ICU and we're looking at week 2 or 3 of their ICU stay, we found that our nosocomial infections have gone up quite significantly. For example, we've been putting in lines, both arterial and central venous lines in our patients for ease of access, and we've seen a surge in our CLABSI risks, our Foley catheters. A lot of our patients have been on steroids, which puts them at risk for secondary infections as well. So when we worked up the fevers, especially in the 2nd to 3rd week, a large component of them have been infectious, either bacterial or sometimes fungal as well.
Yeah, I'd echo what Vikram is saying here. For us, given the fairly kind of robust focus at this point on coagulopathy and anticoagulation, most of our kind of quote unquote recovery fevers tend to be more along the lines of infection because you're sick and prolonged in the hospital and you're hanging out where the germs hang out.
Before I do the polling, Bruce or Paul, any questions for Will or Vikram before I move to the polling? No is fine, yes is fine. Okay, all right, great. great presentations. Okay, so Echo, if you could please put up the polling and see what we come up with here. All right, so these are, imagine this, ARDS related questions. Today, what percent of patients in your ICUs have experienced ARDS? 0, and then it's by different percentage. This is like 15-second question. What percentage of patients in your ICUs have experienced ARDS? Okay. So it looks like the highest number of responses were for 26 to 50%, quarter to a half. Okay, great. All right, thank you. Next question. So, it's pretty straightforward. Compared to April 15th, it was a month and a half ago, a little bit more than that. My approach to ARDS in COVID-19 patients is the same, different, or it doesn't really apply because I don't take care of those patients. Same or different? Since April 15th, tax day. I guess tax day moved actually. Speaking of profound effects of a disease, wow. All right, let's see. Different. So in what, like 7 weeks, 30% say it's different. Fascinating. All right, next. Compared to non-COVID patients, management of ARDS in COVID patients is easier, same, more difficult, or not applicable? Okay. Yeah, 41% more difficult. All right, next. Fluid management. Fluid management has a major impact on outcomes in COVID-19 patients with ARDS. Okay. %37 said yes. 34% said not sure. All right, next. One of the background behind this question, the ECMO question, one of our very first presenters from Minnesota actually talked about ECMO and COVID-19 and wanted to see where that is right now. So my access to ECMO for critically ill COVID-19 patients is adequate, inadequate, doesn't exist, not sure, not applicable. Okay. Adequate, 23%. Doesn't exist, 17%. Inadequate, 11%. All right, thank you. Next. And this is trying to figure out what source of information has been the most helpful in your care of ARDS and COVID-19 patients. And that's your colleagues, fellow intensivists in your hospital, fellow intensivists at other hospitals, peer-reviewed papers, and then professional society, either nationally or internationally promulgated recommendations, guidances, or protocols. And then last on the options is public health. Should have done NAA on that one too, sorry. Okay, let's see. Professional guidances, yeah, 62%. That trends actually, when we did one on critical care rounds last week, that those guidances are what people are really leaning toward with critical care interventions. So yeah, thank you very much. I think that's it. Echo, yeah, right. So I'm going to open this up to the panelists and speakers for any comments based on what you've heard, seen so far during the rounds. Paul, any observations?
I want to thank the speakers. Those were really great talks. And I think the point of the need for long-term ventilation capability, for LTAC capability is extremely important. And I think as hard as it is to ramp up acute care hospital capacity, it's even harder to ramp up LTAC capability. I think it requires a lot more lead time. Your options are a lot less. And so I think certainly not just individual systems, but actually cities and states really need to be focusing on this, because it tends to need to be a collaborative effort among hospitals and systems to make it happen. And unfortunately, as we're seeing, different parts of the country that are seeing increasing waves, now is the time, as they're actually having increasing case numbers, that they should be thinking about LTAC capability, because it'll take that long, that when the wave hits is when they'll actually start to need the capacity. So just phenomenal point.
Yeah, and Paul, as I think about this and the discussions that I've been in, many of you have been, it's been around stopping the disease in the long-term care facilities. I mean, that's what it's all been about. And so this is, at least for me, a great awakening of, and hopefully for the 300 to 400 participants, the dialogue needs to start happening. And so, I mean, just, teasing this out a little bit further. So if that risk can't get mitigated in a way that quickly enough, it's a timing thing. How fast can you mitigate that in the LTACs? And if you can, if we're unable to do that quickly enough, then what's the plan B for that? Because you can't not have a plan B. And
Yeah.
So, yeah.
No, I'm sorry. What I would say is it's really, and I think we should probably generalize or broaden that a little bit more, that it's really the whole post-acute continuum, right? That obviously LTAC needs and the high vent rehab needs are significant, but there are also a lot of folks that are deconditioned that need other skilled nursing facilities, other post-acute care needs. And so it really is a continuum. And as you said, a number of facilities have been hit pretty hard by acute illness as well. But I think it really has to be part of every community's playbook, that as you're seeing rising numbers of cases and as you're struggling to make ED and inpatient and ICU capability available, you really need to be working at the exact same time to make post-acute capability available. Because if you wait until you're sort of handling your surge, you will not have time to manage the post-acute.
Yeah. Okay. Vikram, and then I'll go to Will. Vikram.
I completely agree. And, I think most places in the country are heading towards preparing. I saw in the comments box that Florida has built a bunch of LTACs. New York has as well. And while we go over the three traditional pillars of space, stuff, and staff, at least the staff perspective can be alleviated by using something novel like tele-ICU to expand capacity at these LTACs. So things like that, I think we should be as innovative as we can, because none of us have seen this in the past and don't have clear guidance.
Yeah, thanks. Will?
Yeah, I mean, I think the other thing too is as we, I think, get a little bit more comfortable with the acute or even the subacute management of these patients, I think there will be the realization that we could potentially even utilize these LTACs a little bit more. I mean, getting someone, if you get someone with single organ dysfunction and you're now plugged into a ventilator weaning protocol and everything else is good, I mean, you can move these patients through your system a little bit faster if everybody's on the same page as to, okay, this is how we wean the vent, kidneys are good, our infectious risk is low, let's get these folks through. And I think at the same time, as we just get a little bit better understanding about infectiousness risk as these folks require a little bit longer to heal, I think that may open the floodgates a little bit for moving these people through the system a little bit as well. I know that's a question we've been kind of banding about our institution as a whole is, okay, you've got these folks, they're in the hospital for 2 weeks. Are they still actually infectious? I mean, they're getting better and they look okay. It's just they still need some oxygen. So can we actually just throw a mask on them and send them out to the floor and send them actually to a regular rehab facility, or they need to go to a special ward at a rehab facility? So, hopefully as we gain more knowledge with that might enable a little bit more robust throughput through the system.
There was Bruce, yes, please. Sorry.
Thanks, Rick. Maybe just to follow up, I saw a comment about discharging patients to the community and trying to, as much as possible, avoid long-term care facilities, or when possible, get people back into the community one way or another. I'm curious what recommendations you all are making to primary care clinicians about follow-up, how often to see these patients, how to be assessing them, what you're doing, what you're recommending to your primary care colleagues.
I can start with that, Bruce. I agree. Getting patients safely home as quick as we can is the best chance of success, not only for COVID, but for any critical illness. That said, a lot of our survivors need ventilators, need renal replacement therapy, need physical therapy, which might not be able to be delivered at home. So the LTAC should be seen as a bridge to going home, not as an ultimate destination. Lastly, I agree, primary care has a big role to play, but that would be, I think, a couple of months down the line when patients are able to physically come to their PCPs and ambulate and so forth.
And then when they do go there, what are you recommending those PCPs be looking for and how they be supporting them best?
So that's well described in the pre-COVID literature, something called PICS, which is post-ICU syndrome. And that has 3 pillars to it. One is neurocognitive dysfunction. Patients in the ICU start developing cognitive dysfunction very early on. B is the PTSD of an ICU stay, so there should be some psychiatric or psychology help. And lastly, the neuromuscular weakness that comes from being on the breathing machine. So those would be the 3 pillars to focus on. In the COVID ARDS, a pulmonologist might be helped to get routine PFTs and look at the lung function a bit better.
Great, thanks, Vikram. And Will, anything to add to any of that?
No, I think all of that is excellent. And again, I also think, one of the challenges going forward, much like the point someone raised about the 9/11 cohort, is we can probably surmise right now what these folks are going to look like 3 to 6 months from now, but we don't exactly know. So we don't 100% know what follow-up pulmonary imaging is going to look like or anything like that. So again, I think building our downstream capabilities to handle these folks as they recover and then start to decline again, is an absolute must, as much as it is getting ready on the inpatient side for a potential second wave.
Great. And Rick, I have one more question, just to ask a question one of our participants asked about antibiotic use. And Vikram answered it, but I think I'd love you to talk a little more about how have you all changed your practice of prescribing antibiotics in the ICU for these patients? There's certainly a lot of media focused on over-prescription of antibiotics that's gone on over the last few months. How have you changed your antibiotic prescribing in the ICU setting?
I think every institution in recent years has been increasingly judicious with their antibiotic use. And I think globally, most folks would argue in general, probably shorter antibiotics are probably as good as a little bit longer. I know as we deal with our COVID cohort, we cast a wide net with culture data, procalcitonins for what they're worth in this context, and you know, in all honesty, we kind of rely on continued I won't use the word harassment, but continued input from our pharmacy colleagues as well, as, hey, you know, can we stop antibiotics? Can we stop antibiotics? And so it's become a routine kind of element in our kind of day-to-day ICU checklists of, hey, can we get this fully out? Can we get these antibiotics out? And for a viral entity like COVID, if we're really not seeing that antibiotic or that, you know, that bacterial element on day 2 or so, we're pretty good about pulling off kind of our blanket ceftriaxone azithromycin approach that we utilize.
A couple questions. Well, a comment first and then a question. It strikes me one of the things that's going to be really important to know earlier than later, and you've given me a clue on it, is about a third of your patients, you know, are have real trouble, you know, fibrotic disease, et cetera, or ARDS, will be prone to complications. So how many are admitted to ICU, and then take a third of that, and that gives me like the number that maybe we should expect to get flooded to our communities or LTACs to have this kind of care. So if I've got that totally wrong, but we got to, to plan for that, you got to like think through what are the numbers we're going to have to plan for and what resources you're going to need, the obvious, you know. And so is it LTAC? Is it back into the community? I saw a comment or a question about could home care do this? And what do we need as communities and healthcare delivery systems to be able to do this well if the LTAC capability and capacity is just not there? And so that's something that's certainly now on my radar screen, wasn't before, and will certainly take that back in my role. But a couple of a question here that came up, and there's a question, and I'm gonna Beth Adams asked it. Beth, I'm gonna reframe it a little bit in communication speak, but it was about what guidance should be provided to community EMS providers in caring for these patients. And I think that, or for awareness, we have a lot of EMS providers that join these rounds, even though they are critical care rounds. So we know we have patients who are discharged who are complex chronic care patients. What are the kinds of things that would tip it over the edge for these patients to where EMS would be called, and what should EMS expect to be able to need to provide? So Vikram, and I know you're not like in an ambulance in the street every shift, that's for sure. But yeah, your perspective on that, and Will.
Well, that's a good question, Rick. And you know, we in the ICU get a fair number of transfers from the LTAC nursing homes, so we have a fair idea on what brings them over.
Yeah.
So for example, just picture a person who's bedbound on a ventilator with a PEG tube getting artificially fed. Being bedbound puts the patient up for pulmonary embolism, so blood clots are a huge risk factor. Having a tracheostomy or an ET tube puts them at risk for pneumonias. So pneumonias are not uncommon, and some of these pneumonias will be with extremely drug-resistant organisms, tougher to treat. Being in a hospital, an LTAC, getting frequent antibiotics puts you at risk for C. diff, so diarrhea comes up. Bed sores, pressure ulcers. Those are the big things in my mind. Will?
Yeah, I agree with all of that. And I think the overall, I think the element too of just, marked deconditioning in this patient population as well, and the threshold for threshold for evaluating them and giving them some time to turn around. I think, just kind of that gestalty nature to things is much, much lower, just given these folks and how deconditioned they can be.
With that, I think, we had a really healthy discussion on this. I want to make sure if there's any final comments, and then I think we'll close, but it's given certainly myself, but I think a lot of us to sort of rethink we're in the middle of this like acute response, but there's another response that follows this that's pretty profound. So any comments by any of you on the panel or speakers or Bruce that before we close out?
I mean, I'll add one comment, which I think was touched on earlier in the discussion, but is worth repeating, that, you know, the neuropsychiatric sequelae are significant, and that's going to put an additional strain on the mental behavior health system, which we know, like 9/11, like other disasters, is also going to be under strain from lots of non-ICU related causes related to COVID-19. So I think, you know, the post-acute care, but also the mental and behavioral health care systems, both are really still in a lot of places in their full response phase rather than recovery, and worth paying attention to.
Yeah, and Paul, wasn't ahead of you on it, but we're right there with you on it. We were having a discussion just before we went live about the neurological sequelae. So yeah, that one I could easily see as a future rounds. So with that, I can't thank enough our participants for joining, being very active in the QA, the chat. Wow. All kinds of QA chat. Good job. Great job, participants. Yes, thank you. And to echo, always there. Always there for us and supporting, making sure these rounds go as well as anyone could ever expect. To our panelists, Paul, thanks for always being there. Thank you for always being there. I don't know where the water is. Where's the water bottle? No water bottle? Okay, there. All right, see? And Vikram and Will, great presentations, and have stimulated, I think, for everyone who's been on these rounds and those that will view it on YouTube or in the archives, a lot of important way forward that we're going to really have to like tackle head on. And appreciate your bringing that to our attention and highlighting the challenges ahead. Thanks, everyone. Be safe and be well. Take breaks. Take care of your mental health for sure. And we'll see you on the next one. Bye.